This session focuses on general surgery, highlighting the critical roles of trauma and hemorrhage in surgical practices. Grasping these concepts is vital for effective patient management. Dr. Sangeeta elaborates on different types of hemorrhage, such as physiological and pathological bleeding, and discusses their implications during surgery. This knowledge is crucial for identifying potential complications. The discussion will emphasize surgical hemorrhage, detailing its primary and reactionary types, alongside effective management strategies. This focus is essential for ensuring patient safety throughout surgical procedures. A common cause of reactionary hemorrhage is the slippage of a knot or ligature, leading to unanticipated bleeding. Recognizing this can influence surgical techniques effectively to prevent such incidents. It's important to maintain lower blood pressure during surgery to prevent excessive bleeding. Moreover, sudden spikes in blood pressure after surgery can increase the risk of reactionary hemorrhage. Immediate re-exploration and religation of the surgical site are crucial strategies for managing reactionary hemorrhage. This intervention ensures any bleeding vessels are securely tied to control excessive blood loss. Cryoprecipitate is preserved at freezing temperatures around -42 degrees Celsius, akin to fresh frozen plasma. This temperature is critical for maintaining the integrity of clotting factors. Deficiencies in factor VIII are primarily linked to hemophilia, a condition that significantly impacts blood clotting. Understanding this is imperative for effective patient care and management. 1 unit of cryoprecipitate contains around 15 milliliters of clotting factors, making it a vital resource for managing bleeding. It finds utility across various clinical scenarios. Mismatched blood transfusions can trigger type 2 hypersensitivity reactions, leading to serious health complications. These reactions stem from the immune system's response to foreign antigens introduced via transfusion. Post-transfusion, common symptoms of a mismatched transfusion include pain, fever, and decreased urine output, known as oliguria, which may indicate renal complications. Vigilant monitoring of these symptoms is vital for patient safety. Immediate management of mismatched transfusions involves halting the transfusion and administering medications like steroids and antihistamines. These interventions help mitigate adverse effects and stabilize the patient's condition. TACO, or transfusion-associated circulatory overload, manifests with symptoms such as respiratory distress and elevated blood pressure due to volume overload following transfusions. Treatment typically includes administering diuretics to alleviate excess fluid. TRALI, or transfusion-related acute lung injury, is characterized by respiratory distress and ground glass opacities observed on chest X-rays. Unlike TACO, TRALI usually lacks signs of cardiac enlargement or elevated BNP levels. Differentiating between TACO and TRALI can be achieved through assessing chest X-ray findings and BNP levels. TACO typically shows cardiac enlargement, whereas TRALI exhibits normal cardiac shadowing, guiding treatment decisions. Different gauge cannulas are color-coded to facilitate quick identification. For instance, the 14 gauge is orange while the 26 gauge is narrow. This system aids in efficient use during medical procedures. Wider bore cannulas, like the 14 gauge, are preferred for rapid fluid resuscitation in trauma cases because of their superior flow rate. Understanding these flow rates is crucial for effective patient treatment. Parenteral nutrition can be administered via various routes, with central lines being the method of choice for high-risk patients requiring extensive nutrient delivery. This approach minimizes complications compared to peripheral 4 lines. Complications from subclavian vein insertion include pneumothorax, which may arise if the needle inadvertently punctures the pleura surrounding the lungs. Recognition of this risk is essential for safe practice. The internal jugular vein stands as the most common site for central line insertion, prized for its accessibility and lower associated risks compared to the subclavian approach. Conversely, the femoral vein is the least favored site for central line insertion due to elevated risks of infection and thrombosis, given its location in the groin region. Cauteries are indispensable surgical instruments utilized for incisions and minimizing bleeding during procedures. They possess the ability to both cut and coagulate tissue efficiently, thus enhancing surgical safety. There are 2 primary types of cauteries, monopolar and bipolar. Monopolar cautery requires a grounding pad and poses certain risks for patients with pacemakers, while bipolar cautery does not. Surgical blades such as numbers 11 and 12 are critical for making precise skin incisions. Number 11 blades are frequently employed for stab incisions, particularly when draining abscesses. Krill sutures are absorbable materials that dissolve within 60 to 90 days, making them ideal for bowel and bladder repairs. This provides an added convenience by eliminating the need for postoperative removal. Proline sutures, also known as polypropylene, are synthetic and non-absorbable, commonly utilized for vascular repairs and rectus sheath repairs. These sutures provide enduring support essential for tissue healing. Silk sutures are derived from silkworms and are natural as well as non-absorbable, making them a preferred choice for skin suturing. Removal is required post-healing, reflecting their temporary nature. Keloid scars necessitate careful treatment planning, as surgical options may differ based on the scar size and location. Radiotherapy can aid in minimizing recurrence after excision. Ulcers, such as venous and arterial types, display distinct characteristics that include margin shapes and pain levels, which are crucial for accurate diagnosis and management. Trophic ulcers often present without pain due to underlying neuropathy, making it imperative to recognize their presentation, especially in patients with diabetes and leprosy. Management of septic shock requires immediate interventions, including fluid resuscitation and the administration of antibiotics. Timely treatment can significantly enhance patient outcomes in sepsis cases. The SOFA score, or Sequential Organ Failure Assessment, evaluates the severity of sepsis and the extent of organ damage. This assessment score is crucial in clinical evaluations. Conversely, the XOFA score serves as a rapid assessment tool to identify patients at risk for sepsis, incorporating parameters such as low blood pressure and altered mental status. Immediate fatalities from trauma often result from severe head injuries, a crucial aspect for frontline medical responders to recognize. This awareness can greatly influence survival rates. The first hour following trauma is known as the golden hour, during which quick medical intervention can significantly lower mortality rates. It's essential for responders to act promptly within this critical window. In mass casualty situations, triage plays a pivotal role in prioritizing patients based on their likelihood of survival and injury severity. Effective categorization optimizes resource allocation and can save lives. Disability management, D, is a vital component of the ATLS protocol, ensuring that a patient's neurological status is assessed during life-saving procedures. Understanding this element is fundamental to effective trauma care. Resuscitation follows the ABCD framework, prioritizing circulation management, particularly in cardiac arrest situations. This methodical approach significantly improves patient outcomes. The secondary survey encompasses comprehensive history-taking and the identification of injuries that may not be immediately visible. This thorough evaluation enhances treatment strategies and overall patient management. The cuff in tracheostomy tubes is designed to inflate and secure the tube in place, ensuring proper positioning during mechanical ventilation. This aspect is critical for patient safety. Patients undergoing mechanical ventilation often lose their cough reflex due to muscle relaxants, which raises the risk of aspiration. Cuffed tubes are thus essential in this scenario. Cuffed tracheostomy tubes are preferred in critical care settings, especially for comatose or intensive care patients. Their use reduces the risk of pneumonia and lung abscess development. Monitoring urine output is a key clinical indicator for assessing fluid adequacy in patients. This metric can help determine the sufficiency of administered fluids. All forms of shock typically result in hypotension and tachycardia. However, neurogenic shock is characterized by hypotension and bradycardia, a condition stemming from spinal cord damage. In head trauma cases, various types of skull fractures can occur, including linear and depressed fractures. Understanding these fractures is essential for determining appropriate treatment and management. Hyperdensity observed on a CT scan indicates potential bleeding or hemorrhage, while hypodensity points to reduced blood supply leading to necrosis. Recognizing these densities is crucial for accurate diagnosis. Intracranial hemorrhages can be categorized into 4 types, including epidural and subdural hemorrhages. Each type has unique characteristics visible on a CT scan, facilitating diagnosis. A sudden, severe headache is a common symptom of subarachnoid hemorrhage. This condition typically requires conservative management unless complications emerge. Evaluating the eye-opening response involves scoring patients on whether they open their eyes spontaneously, in response to voice or to pain. E4 corresponds to spontaneous eye opening, while E1 indicates no response. The verbal response component assesses whether a patient is oriented or confused. Scoring ranges from V5 for fully oriented to V1 for no response. Confusion can yield a score of V4, while inappropriate responses score V3. Motor response evaluation is based on the patient's ability to follow commands and localize pain. A score of M6 is for obeying commands, while M1 indicates no motor response. The teardrop sign serves as a vital indicator of orbital fractures, where soft tissues protrude into the maxillary sinus, necessitating careful imaging analysis. This sign is typically identified during a CT scan. In thoracic trauma cases, a chest X-ray is the initial investigation, followed by ultrasound to evaluate for bleeding in the thorax. Rapid ultrasound, referred to as EFAST, is essential for emergency assessments. Common mortality causes in blunt thoracic trauma include tracheobronchial injuries, while penetrating trauma often results in massive hemothorax. Recognizing these injuries is critical for prompt intervention. Hyperlucency on X-rays indicates an excess of air surrounding the lung, commonly seen in tension pneumothorax cases. This sign aids in distinguishing affected lung areas from normal ones. The ABCs of tension pneumothorax encompass low blood pressure, breathlessness, and distended neck veins. Recognizing these symptoms is essential for swift diagnosis. Emergency management strategies include needle thoracostomy or chest tube placement to relieve pressure, crucial interventions that restore lung function and enhance patient outcomes. In stable blunt abdominal trauma cases, a negative FAST exam may lead to patient monitoring, while a positive outcome necessitates further imaging to assess for internal injuries. For unstable patients with blunt trauma, the FAST exam plays a critical role in identifying active hemorrhage, prompting immediate surgical intervention through exploratory laparotomy to locate and control bleeding sources. In penetrating abdominal trauma cases, the presence of hemodynamic instability, even in the absence of a FAST exam, demands prompt surgical intervention to address potential peritoneal breaches. Managing peritoneal lavage becomes essential in instances of infection or inflammation, aiding in the cleaning process and mitigating complications associated with peritonitis. Understanding the zones of retroperitoneal trauma is crucial for assessing damage and determining intervention strategies. Zone 1 trauma, which involves major vessels, often requires surgical exploration due to a high risk of bleeding. Angioembolization serves as the preferred initial treatment for Zone 2 or 3 retroperitoneal trauma to control bleeding, but if this method proves ineffective, surgical exploration becomes necessary for patient stabilization. First-degree burns are characterized by redness, swelling, and pain, primarily affecting the epidermis. Common causes include sunburn and exposure to hot liquids. Second-degree burns are further categorized into superficial and deep types, with blistering occurring in superficial burns. This injury damages both the epidermis and the superficial dermis. Third-degree burns involve damage extending through all skin layers, potentially resulting in areas devoid of pain due to nerve damage. Treatment for these burns often necessitates skin grafting and removal of necrotic tissue.